I'm going to kick it over now to Dr. Reuben Strayer. If you're wondering who the quintessential badass ER doctor is, it is Dr. Reuben Strayer. He is our associate medical director. He's giving me a glare right now. I can see it through the camera. So he's the associate medical director at MIMO. He tweets at EM Updates, and he blogs at emupdates.com, and he talks about many, many different emergency medicine topics. He thought it was really important that I tell you that he lures himself out of bed every morning with chocolate. And I will say that Dr. Strayer always shares his chocolate and his brownies on shift. His love language is feeding, and our love language as residents is eating. So I'm going to pass it over to you.
Thanks, Sabina. So that's my first pearl is chocolate morning, noon, and night. You really can't go wrong with that. So it's nice to meet all of you virtually, even though this is a webinar, a Zoom webinar. So I actually can't see any of you. I can just see my fellow panelists who I see every day, and I don't need to see any more of them. But still, nice to see all of you virtually.
We love you too.
I've been at MIMO for 4 years. I've also been faculty at Sinai and at the Elmhurst site, and also at NYU Bellevue. So I have a fair amount of experience in a variety of different New York City emergency medicine residency programs, and that gives me a good perspective on the strengths and weaknesses of MIMO and the others. So there's a lot to say about what makes MIMO unique and interesting, but I'm going to start with what I think is probably the aspect of being a resident at Maimonides that affects your perception of yourself and of your residency more than any other, which has to do with our kind of crazy spectrum of disease. And from there, I'll take a moment and describe our teaching resident block, which I oversee, and then I'll spend a moment discussing our programming around opioid use disorder. So MIMO sits geographically in between several really unique populations. It's really interesting. First is a huge swath of underserved immigrant communities that speak every language other than English. And that's sort of one aspect of what we do. That's a huge section of our patient base. And then sort of on the other side of the tracks, as it were, is the largest Hasidic Jewish community outside of Israel. And that presents many unique challenges and opportunities. But in particular, both populations offer this very unique preponderance of critically ill patients. On the one hand, you have a huge section of Brooklyn where folks are marginalized. They don't get care. They are very confined to their hyperlocal immigrant communities. And so what that means from a hospital perspective, from an emergency medicine perspective, from a training perspective, is that they just don't come in until they are nearly dead. And it is just routine for, I'll be working a triage shift, and they'll ambulance will come in with this 900-year-old Chinese man, and the story is well, he's been vomiting blood, and but this has been going on for some days, and then today he couldn't get out of bed, so his wife called 911 because until then he was refusing to come to the hospital. And you see him, you kind of walk up to him, and he looks horrible, and then you are he's not really saying anything to you, so you just put your hand on his, and it turns out that he has no pulse. This is a fairly normal situation, just because of just the crazy lengths that some of our population will go, some of our patients will go to not avail themselves of medical care. And that's, of course, a horrible situation from a societal perspective. Maybe Kamala will fix that. But until then, we just have this huge section of our patient base that just doesn't get care. And so bad for living, but great for emergency medicine training. And then on the other side of the tracks, you have tens of thousands of very religious Hasidic Jews, which think of us as their personal hospital. And they have great access to medical care. In fact, they have too much access to medical care, but they also have very specific ideas about end of life care. And what that means is that we also have the opportunity to care for huge numbers of patients who are actually dead, but still have a pulse. And these patients sort of present to our resuscitation bays all day long, and all of them, they're critically ill. They're critically ill at their baseline. And so you have just tremendous opportunities to utilize your critical care skill set and to perform critical care on huge numbers of patients. Again, I've worked in lots of big hospitals, Bellevue, Elmhurst, Sinai, and the spectrum of illness here is just outrageous. And our residents become extremely comfortable managing critical illness. In fact, I would say a little bit too comfortable, but that's a good problem to have. And we're also lucky that we have the support of the department and the hospital to sort of get all of the necessary services and tools to care for such a critically ill population. So we have a great airway management program. We have all of the toys. We have we have a CMAC and a glide scope, which we use frequently. We also recently, it's been about a year now, I guess, we have flexible disposable endoscopes, bronchoscopes, which has really lowered the bar to just rip one of those things off the wall, stick it in someone's mouth or nose, and then when you're done, you just toss it. So what that means is that instead of having to use the super expensive piece of equipment, which when I was training, I felt like I had to have a really good reason to break that thing out. Now it's like if someone has a sore throat, I'm taking one of those A-scopes and shoving it down their nose and seeing what's going on down there. And what that means for me and my residents is that we get this a lot of experience with a really important skill that a lot of emergency medicine residents don't get good with. And I certainly didn't get good with it as a resident, and I had to learn the technique after residency. So we have a lot of other cool resuscitative tools. We have a great transesophageal echo program, mostly for intra-arrest, where we drop a TEE probe down intra-arrest and can do all sorts of cool things. With that, we're a level 1 trauma center, of course, and we have an aggressive ECMO service. So when we have a patient that would benefit from ECMO, we call them and they will come in 24/7, and it is astonishing how fast they can get someone on pump. So lots of really cool opportunities to hone your critical care skill set, but mostly it comes down to just the incredible spectrum of disease severity that we see, and the patients who are just so sick and just need resuscitation constantly. So I'm just going to take a moment and briefly mention a couple of other things that I'm uniquely involved with. The first is that during your third year, I supervise the so-called teaching resident block. It's a 4-week block, also called the admin resident. It's a 4-week block during your third year. I started this at Sinai about a decade ago, and I learned from the mistakes we made there for the teaching resident there. And so I've been able to hone that, I think, better to make a really good experience for both the residents and the program during their teaching resident admin block. And it's a really great 4 weeks where residents are protected from their clinical responsibilities and can focus on other aspects of emergency medicine, teaching aspects, administrative aspects, which you don't get a chance to really think about while you're just busy, going from 12-hour shift to conference to a binge drinking to another 12-hour shift. So there's a variety of different aspects of the month. The big one is teaching. You do a lot of disseminated teaching over email, blogs, Twitter on a daily basis. You do a lot of in-person teaching, junior residents, medical students, EMS providers. You do direct observation of junior residents and medical students, which is actually really great, both for the medical student and the junior resident who's being observed, but also great for the observer. You learn a lot. And then, of course, there's all of the meetings that you get to go to, which some are better than others, but they're all great learning experiences. And it's really important to know, I think, how an emergency department functions, which happens generally in the boardroom. There's a patient safety aspect where all of our residents actually review 72-hour return bounce backs for opportunities for improvement to see if there's any problems with the care. And the teaching resident reviews all of those cases every month to develop a presentation where they present the most important learning cases from the patients who bounce back, needed to be admitted, and may have opportunities for improvement in their care. So that's the teaching resident month. And lastly, MIMO has developed a great program, a pretty advanced program for addressing opioid use disorder. And despite not being in a neighborhood where there is a huge prevalence of opioid misuse, we have been one of the leaders citywide in developing this programming, in addressing what was until a few months ago our most important public health crisis. So we were the first emergency department in the city to routinely administer and prescribe buprenorphine for opioid withdrawal syndrome. And in fact, now we have evolved to be able to give charity buprenorphine to patients who have no other way of getting it, who have no money and just can't afford their bupe. We can actually give them a week's worth of free buprenorphine, which is pretty incredible. I mean, we're talking about a Schedule III controlled substance, which we can just hand out into their hands, which is pretty amazing. Our pharmacists do take-home naloxone to anyone who wants, whether you're a registered patient or not. And so anyone who can present to our emergency department and leave with 2 doses of nasal naloxone in their hand, and that's an amazing public health initiative. The hospital MAT clinic, the Medications for Addiction Treatment clinic, an outpatient clinic, is run by emergency medicine, me. So there are a lot of possibilities there for education, and also a lot of opportunities for continuity of care for patients that you see in the department. And then lastly, we have incorporated X-waiver training into the resident curriculum, so that by graduation, the idea is that all of you will be expert in identifying and managing opioid use disorder and affecting its most important treatment. I have to exit this session, but I am always happy to answer any questions about MIMO EM. I'm also happy to answer questions about other programs that I'm familiar with, and the New York City sort of emergency medicine residency scene in general. Please email me, emupdates@gmail.com. Thanks everyone, and I look forward to meeting you in Brooklyn.
Thanks so much, Dr. Strayer. Working with him is an experience, just constant learning. The cultural difficulties applies to, we have just so many cultures, like Dr. Strayer said. And thankfully we have our patient representatives come from various different races and cultures, ethnicities. We have a couple translators that are constantly there for our Chinese community. There are a lot of measures taken to try and make sure that we're respectful and sensitive to all the cultures that MIMO serves.